Okay, so we're moving into part two, and this is where we're going to talk about kind of that process of weaning. We kind of in part one we assess our readiness to wean. Now we're going to talk about the process for doing those weaning trials. Anytime we're looking at potentially um, moving into like a weaning trial with a patient, we want to make sure that we're preparing the patient properly. So we usually do our weaning trials in the morning after the patient's rested and they're stable overnight. I would say that you want to always maximize your patient condition respiratory status by giving them all their breathing medications, doing your bronchial hygiene, all of that stuff before attempting the pressure support trial or whatever weaning method you're using. Um, Again, I mentioned communication is an important part to minimize anxiety. Explain things very clearly to patient, reassure them that you're going to be in the room with them so that if they have difficulty breathing that you can, add support if needed. Um, you want to make sure that the patient's got that optimized nutrition, acid base status. You've double checked all those other systems with the nurse to make sure that they're in a good condition to try weaning. You want to minimize the amount of sedation that the patient's on. Um, and two, just remember that you have, patients that have been on the ventilator for a couple days or been in the ICU, they have a lot of risk for those psychological disturbances, especially if they've been on a lot of medications. Delirium's a big thing in the ICU. I think we've talked about that throughout the program. And you might have seen this at clinicals that so we do things in the ICU to kind of help reduce the risk of starting of the patients getting delirium, ICU delirium. So it's like reducing the noise, giving them clacks, radios, rooms with windows. Another big thing for us is just that daily mobility. So getting the patients up and out of the bed. Not only does that help with their respiratory muscle strength, but their, airway muscle strength, but it also just helps with their mentally. Another thing that we like to do for patients is that they, if they wear glasses, give them their glasses, put their hearing aids in, give them communication boards. All of those things help make the patient feel a little bit more human, more part of the process that helps with weaning. All right. So we talked about three basic methods of discontinuing ventilation in the kind of the first portion. We talked about spontaneous breathing trials. This is usually where we're taking the patient off the mechanical ventilator, putting them on the T-piece, using SIMV, using pressure support. There's a box on page 1194 that kind of gives you the evidence behind the different methods of discontinuing ventilation. Again, all of these would be fair game on an MBRC exam, but so I would kind of just be aware that even though we see pressure support being kind of the most used method in our area and probably at clinicals, any of these are acceptable weaning methods per the MBRC. So rapid vent discontinuation is going to be for patients that, usually have their initial problem corrected within 72 hours. They've achieved good weaning parameters. They have good spontaneous breathing trial results in that first, 30. Usually spontaneous breathing trials don't last more than around 30 minutes to, sometimes up to 2 hours. So if the above criteria are met, these patients are quickly removed from vent support. Okay. And if the patient can protect their own airway, that means that they're getting extubated as well. Patients that are going to need that more progressive weaning. This is somebody who is usually patients that are on more longer term ventilation. They have that marginal oxygenation ventilation needs, or they have other medical conditions like cardiovascular or medical statuses that are not completely within the normal limits. So the most common method for weaning these patients is usually like a spontaneous breathing trial, alternating with rest periods on, either AC or SIMB, or you might just give them significant levels of pressure support in between. So that doesn't mean that you're not trying these patients that are kind of fitting into these categories. That doesn't mean that you stop trying to wean them until they're getting corrected. You still do that weaning to try to, encourage that their respiratory muscle use without allowing them to become fatigued. Okay. So we're talking specifically about spontaneous breathing trials. So usually this is kind of the oldest method of weaning a patient, where we're putting the patient typically on a T-tube. So T-piece hooked up to an aerosol device. This allows the patient to spontaneously breathe through their endotracheal tube. So usually we'll do that for a little while, and then we'll put them back on the mechanical ventilation for more support. So they'll have a period of being on the spontaneous trial for like 60 minutes. If they're successful, even if they're successful, we'll put them back on the ventilator to rest them. So for really gradual weaning, that first trial might only be 5 to 10 minutes, where we're only just given it. A thing to remember is you don't want the patient to completely crash and burn and fail, especially if you think that this is a gradual trial. It's just like exercising, right? If I would tell myself, it's been a while since I've run, if I would tell myself, oh, I'm going to go get out there and I'm going to start running again. And I decided that the first run I was going to go on was going to be a 7-mile loop, and I was going to run at a 6-minute mile pace, which I haven't done since I was in my 30s, early 30s, late 20s. So, if I decided that that was going to be my goal of getting back into running, I would crash and burn probably not even a mile into that if I was trying to run at a 6-minute mile pace. And I might just be like, yep, that's it for me. I'm just going to walk home now and be done. But if I started off gradually, where I told myself, okay, I'm going to get into running, I'm going to run for 2 minutes and I'm going to walk for 2 minutes, and I'm going to run for 3 minutes and I'm going to walk for 3 minutes, and I gradually build up my stamina, it would be a lot more successful and I wouldn't get as discouraged. Same thing with our patients and their breathing. We want to, give them achievable goals. So we might start off with this 5-minute spontaneous breathing trial, and then give them an hour to 4 hours of rest on AC, or put them back on pressure support at a high level. So gradually we're going to increase that amount of time that they're being asked to spontaneously breathe, while decreasing the amount of rest period. Okay. We should always be resting our patients overnight. Okay. You can also do an alternate method where you're, putting them on that spontaneous breathing trial for a day, and then, switching them off and resting them the next day. So research has shown a lot that there's been a lot of research done on spontaneous breathing trials. Um, and some of the advantages of them are going to be that um, the patient is going to, you know, you're going to really be testing that patient's ability to breathe on their own without any support. Um, Usually using multiple spontaneous trials a day usually isn't the favored method, because it requires so much time on our part to be at that bedside and switching them back and forth. But research does show that that single daily spontaneous breathing trial of like 30 minutes to 120 minutes can be just as effective as doing several throughout the day. So, okay. So, there are things that we should be looking for when we are doing these spontaneous breathing trials. If you observe any signs of distress, like agitation, anxiety, diaphoresis, altered mental status, if their respiratory rate goes up to like 30 or 35, their SpO2 drops, there's a 20% change in heart rate or a heart rate greater than 120 to 140, or there's a big change in their blood pressure, you should then be stopping the weaning trial. Okay, so even if I get 5 minutes into it and any of these things happen, and my order says to do this for 30 minutes, I'm only doing it for 25 minutes if I see any of these things happen. Okay, I would commit these to memory. These are important factors for you to identify quickly, and this is going to be an excellent way of giving you an MBRC question, right? Is making sure that you can identify that the patient's not tolerating the weaning trial. Okay, so if you have an unsuccessful weaning attempt, you should be putting the patient back on vent support, and you should wait until the next day. It's not like I'm going to have this happen with my patient at 7 in the morning and then at 9 o'clock be like, okay, we're going to try again. And then, because all that's doing is it's overtaxing those respiratory muscles and leading to more and more respiratory muscle fatigue. So I really need to give that patient 24 hours to rest. Okay. All right. So your book talks about CPAP as well. So you can use CPAP during spontaneous breathing trials at facilities where you're just putting the patient on, anywhere from 5 to 10 a PEEP and allowing the patient to breathe spontaneously over that. That helps compensate for patients with auto PEEP, especially if they have obstructive lung disease. The other advantage of this is that you're on the ventilator, so you have those alarm systems. So that's helping you monitor your patient. And another thing that that can do is it's just I think I already said that, like just can help compensate for things like auto PEEP with your patients and keeping your airways easy to trigger. All right, so SIMV, using SIMV, again, this is a partial support, can be a full or a partial support mode depending on the rate you have set. So when you're using this as a weaning mode, you're just gradually reducing the machine rate that you have based on your patient's ABGs and the patient assessment. So the patient is gonna gradually start assuming more and more of the working breather. There have been early studies on this that said that it was going to be better, but there hasn't been any backup studies or repeat studies to substantiate that. So again, one is not better than another. You would just, usually it's going to be site dependent on which method you're using. Know though that if you're really struggling with somebody to wean, you might want to alter the type of weaning protocol that you're doing based on patient specific criteria. But for like the MBRC or those types of critical thinking questions, any one of these, all are created equal. It's not like you would pick one over another in a certain situation. They're just going to give you usually one of these as an option for extubation or weaning. Think if anyone wants to say anything else. Not really. So, so usually with you're using SIV, again, you're using the pressure support in conjunction with that. So you're going to set that pressure support to help your patient achieve good spontaneous volumes, but you don't want to be doing it all for them, right? So then you're going to gradually reduce the amount of support. So typically you're going to gradually reduce your respiratory rate by 2 breaths per minute until the patient's completely on essentially pressure support. Okay, so moving into pressure support weaning, this is the one that we're most used to because this is the one that most of our clinical sites use. Um, so the benefits of this is it allows for the patient to have significant control over the process. Um, they're gonna decide when the breath starts, when the breath ends, so they're controlling a lot of it. You're usually using pressure support to achieve tidal volumes of 4 to 8 milliliters per kilogram. Again, I like to start high with my pressure support and gradually reduce it to minimize to like that low value, whatever my protocol says. And that low level, that 5 of pressure support is usually there just to compensate for worker breathing on the ET tube. Again, we're looking to rest our patients at night. And usually we're, continuing ventilation if the patient tolerates pressure support of 5 to 8 with no distress, or tolerates CPAP with no pressure support with no distress. So either one of those is a reason why that patient would be ready to extubate. Okay. So spontaneous awakening trials, this is like your sedation vacation. So there's always a big concern with using sedation for critically ill patients. Um, so it's been increasing in the last couple of years with the issues with delirium. So we use those spontaneous awakening trials along with those spontaneous breathing trials to fasting weaning of a patients and decrease that mortality risk in the ICUs. So your book talks in table 53.4 about different types of sedation scores that are used on mechanically ventilated patients. So that they talk about the Ramsey sedation score, the Richmond agitation sedation score. So these are scores that just tell you uh, how well your patient's sedated. So typically, and at the bottom of each of the charts, it tells you what the ideal score should be. So the Riker score, ideally you want it to be 4. Anywhere from 3 to 5 is acceptable. For the Ramseys, it's anywhere from 2 to 4 is acceptable, but ideally 2. And the Richmond score, you want them to be, alert and calm on that Richmond score. Okay, there's newer techniques to facilitating vent discontinuation. So there's mandatory minute ventilation. This was introduced a long time ago. This is where the total minute volume is set. The patient may elect to inspire all the minute volume, part of it, or none of it. So the patient, I'm setting the minute volume. I can say I'm setting it at 5. The patient can do whatever portion of it they want, and the vent will make up the difference. ASV is adaptive support ventilation. This is again a newer mode of ventilation that maintains minimum minute ventilation with an optimal breathing pattern. So we're looking at adequate tidal volumes and adequate respiratory rates. So it automatically adjusts inspiratory pressure and the ventilator breath rate to achieve that target minute ventilation. We have computer-based weaning, which is a kind of computer-controlled mechanical ventilation, which there's several complex systems that have been developed, like Ventilation Manager, VQ Attending. They're all kind of listed there. So these are kind of the development of these was based on kind of 2 factors. So weaning can be time consumer and labor intensive. So if we allow our computer to control it, it can kind of expedite the process. And the second thing is that sometimes it's hard to remove that objective portion of vent weaning, and we want to or that subjective portion of it, and we want really weaning decisions to be based on objective data. So that's what kind of developed this computer-based weaning. So the most successful of these are that SmartCare approach. This system adjusts pressure support based on the patient's tidal volume and respiratory rate and end tidal levels. So it's going to adjust it up or down automatically at the beginning of those spontaneous trials. Automatic tube compensation is another method. This compensates for flow dependent pressures in the ET tube during inspiration and expiration. So it's going to reduce that work of breathing for the patient and improve their comfort. Because remember that just by having that endotracheal tube in, that's going to increase my work of breathing. So it compensates for that work of breathing from that artificial airway. Sometimes it's referred to as electronic extubation. Volume support. Your book says it's a newer mode of ventilation, but I've been using this for 20 years. I've been in respiratory therapy, so I don't know how new I'd call it. Combines pressure support with volume ventilation. So it automatically adjusts that pressure support to maintain like a guaranteed tidal volume or a targeted tidal volume. So it's going to automatically adjust that pressure support in like kind of a stepwise fashion. But it's the same. This has the same problem that PRVC has, where if you have that excessive reduction in airway pressure when the patient's making an effort, that's going to then increase that patient effort moving forward. So the same thing like what we did when we were looking at PRVC. So I didn't want to go too much into that proportional assist ventilation, neuro assist ventilation. Those are kind of the newest modes. These, again, do not force a ventilatory pattern. It just looks at what the patient desires and then tries to synchronize with it and support it. There's not really any data right now or studies right now of how it helps facilitate vent discontinuation. But just based on how it improves that patient vent interaction, I would say that it's probably an effective way of using mode for using with spontaneous breathing trials. Okay. We also use non-invasive ventilation as kind of an adjunct to vent discontinuation. So there's three different manners. So we transition patients with COPD who failed that spontaneous breathing trial from invasive ventilation to spontaneous breathing. So if we have a patient that's a COPDer who's been on the vent for a while, we know that they're not going to be able to sustain spontaneous breathing on their own. We're going to extubate them. We're going to put them right on non-invasive. You guys have probably done this already at your clinical sites. We also use it for patients who've passed their spontaneous breathing trials but are still at high risk for failing extubation. Or we use it to support patients who develop hypercapnic, carbic, or hypoxemic vent failure after extubation. So after extubation, if they go into hypoxemic or hypercarbic failure, rather than just reintubate, we might just put them on a non-invasive. High flow nasal cannulas are also effective. So you can, try to stave off reintubation on your high risk patients. I put them on a high flow nasal cannula. Typically, for every 10 liters you're using with an adult patient, you're getting 1 centimeter of CPAP. So, if I put them on 5 liters or 50 liters of high flow nasal cannula, I'm giving them essentially 5 of CPAP. So you can use this on patients that just need like that PEEP CPAP to help support their oxygenation, but really if they need that supportive ventilation, you should be considering non-invasive instead. Typically, if a patient has, after extubation requires reintubation or non-invasive support. That's kind of within 24 or 48 hours. That's kind of a sign that they failed weaning or discontinuation. So role of mobility, this is again that you don't move it, you lose it. Kind of realm of thinking. So it's very, very clear that when it comes to patients in the process of weaning for ventilation, mobilization is really, really important. Mobility mobilizing a vented patient could be as simple as sitting them up on dangling them or sitting them up on the side of the bed. If we call that dangling our patients. So in many cases, your patient could even be taking a walk down the hallway with their vent support. And it's even after we extubate, again, getting the patient up, getting them moving is going to help the patient from requiring going back on vent support. The role of respiratory-driven protocols in weaning, by having respiratory therapy driven protocols, that helps us wean our patients faster. That's just because by using these protocols, we're able to not act independent of our physicians, but follow like a specific algorithm to make weaning decisions to help facilitate the patient getting off the ventilator rather than waiting for those individual vent orders. So usually when if you're ever in the position to help develop a protocol at your facility, again, you always want to make sure that it's evidence-based. You're looking for best practices, doing a literature review. Those earlier studies show that IMV can be useful, but I would say that that's pretty much fell on by the wayside. Most places find that spontaneous breathing trials that last like 30 minutes to 2 hours are the primary approach to weaning, with pressure support being kind of an adjunct to that. Monitoring during weaning our patients. So we want to monitor our patients' ventilatory status. Our PCO2s should be somewhere around 40 millimeters of mercury with low RSBI. So the higher your RSBI, your frequency divided by your tidal volume is, the more likely you're going to have that vent failure. So if you have an RSBI less than 105, or this frequency divided by tidal volume, that's how I calculate your RSBI, less than 105, that usually indicates that the patient's going to be able to sustain spontaneously breathing. You're going to want to make sure that you're monitoring their SpO2 continuously. It's always good to have end tidal on your patient, that capnography, but it can be misleading if your patient's got, really, really sick, because, obviously perfusion plays a factor in that. So again, oxygenation is going to be assessed with looking at that continuous SpO2 monitor. Cardiovascular status is going to be continuously assessed with pulse, blood pressure, rhythm checks. So any changes in any of these, as mentioned before, you would consider that a weaning failure. You'd terminate the spontaneous breathing trial and put them back on full support. Okay. All right, so talking about extubation, remember that extubation and weaning are two separate decisions. So I'm going to be assessing my patient for readiness to wean every single day, but that does not mean that I am going to extubate my patient if they pass their weaning trial. Extubation requires the ability to protect the airway first and foremost. So they have to have an intact gag reflex, effective cough. I also want to look for airway patency, that minimum of edema, that positive leak test, meaning that if I deflate the cuff, I'm hearing the leak around the ET tube. And, to be even more specific, I should see about a 20 12% or greater volume loss between the volume that got delivered to the patient and the volume that's coming back from the um, to the vent. And then finally, we want to look to make sure that our patient has adequate bronchial hygiene. So that means that the patient has an ability to clear their own secretions. So if they, have a lot of excessive amounts of secretions that are really thick and tenacious, they might not be able to um, uh, clear those after they get extubated. Um, so remembering too, artificial airways can affect the ability to can affect the patient's work of breathing. So if you have a patient that you're looking at weaning and removal of that endotracheal tube, make sure you have an adequate size ET tube in. So if I have an ET tube that's very, very small for my patient's size, or pretty much in general, ET tube of less than 7 for an adult is way too small, and that's going to increase my airway resistance. Also, remember that biofilm builds up on those endotracheal tubes, and that biofilm is going to dramatically increase your airway resistance because it's going to be occluding that airway. So we want to make sure that we're providing adequate humidification to our patient. We're going to carefully suction our patient. We might want to consider tracheotomy tubes. We might want to consider all of those things to help facilitate weaning our patient from vent support. So patients, patients who have been successfully extubated generally have, the following characteristics: resolution of the disease or condition state, hemodynamic stability, absence of sepsis, adequate oxygen status, and adequate vent status. So the decision to extubate should then be based on the upper airway patency and the ability to protect it. Okay, so some patients still might be successfully extubated even if the criteria above wasn't met, but they're going to be at risk for reintubation, and you want to make sure that you're ready for that in case that happens. Okay. Some post-extubation complications could include, hoarseness, sore throat. These are just refreshers from when we talked about this in airway management. So common problems afterwards are like airway obstruction or increased risk of aspiration or just difficulties clearing their secretions. You could have, airway issues post intubation. So we want to make sure that we're assessing again for any obstruction before extubation. And then you can have that glottic edema after extubation that can cause that stridor. So you would want to make sure that you are prepared to manage their stridor. And again, we do that with racemic epinephrine, cool aerosols, and then potentially even reintubation. Okay. Vent discontinuance or failure. As many as 25% of people are removed from vent support, need to be reintubated. Okay. So patients, half the patients with distress following that discontinuation are going to show that marked hypercapnia. So their blood gas is going to show that really high increase in CO2. Unsuccessful spontaneous breathing trials have even been shown to be related to things like cardiovascular stress or MIs. Patients who, have a inability to wean, that can be, attributed to sometimes that psychological dependence. Been on the vent's been helping you. You feel like you can't do it without it. poor oxygen status or cardiovascular instability, but most commonly it's because of that imbalance between what your lung muscles, respiratory muscles are capable of with overcoming increased resistance or decreased compliance, and what demand your body has, or how much CO2 your body's producing. So that kind of common causes of weaning failure are listed on 1206 and box 53.14. All right. So prolonged ventilation is going to be required for about 3 to 7% of all vented patients, while less than 1% actually become dependent on the ventilators. Special long-term acute care facilities specialize in weaning these patients. So typically these patients go there, help with that long-term weaning goals. So once they have kind of establish that the patient is going to become vent dependent, then they're going to just look at trying to restore the highest level of independence for the patient. So trying to make them as independent as possible of that vent need. So maybe not needing to be on the vent all day, but maybe just at night, whatever they can accomplish for the patient. Terminal weaning is a term we use when we're discontinuing vent support in the face of that catastrophic or irreversible illness. So this decision process is usually very emotional and has a lot of ethical and practical problems. So usually the decision is going to be made by the family along with the patient's physician in accordance with whatever the ethical legal guidelines at that facility are. So not that respiratory and nursing who are caring for the patient aren't sometimes part of those discussions or not supportive in those discussions, but it's really up to that family and that doctor to make those types of decisions, and that doctor to have that conversation with families. So this decision is usually dependent on the patient's desire to not continue life support, low chance of survival, low chance of that good outcome, the low chance of, future cognitive function. So this is usually the decision's then usually kind of made to discontinue the ventilator rather than wean it. And usually this should be done as humanely as comfortable as possible for the family. So usually when they're talking about these types of decisions, they're looking at placing the patient hospice afterwards, making the patient comfortable, and making their passing as dignified as possible. All right. So that concludes part 2 of your lecture. If you have any questions, please let me know.